Hi, good morning, everyone, and thank you. So for this project, I worked very closely with Laura Padilla, who's a very active member of this group. I think a lot of you may have encountered her if you're participating actively on the forums and so on with publications and task groups. Unfortunately, she was not able to come, but I will try to do my best to replicate her presence and give this talk on behalf of what we've been working on. So today I'm going to be talking about how we implemented SGRT into our patient setup for SBRT treatments. The tongue twister right there, SBRT, SGRT. And we are trying to evaluate whether or not basically setup accuracy with SGRT compared to the treatments that we delivered without it in the past, or otherwise our so-called traditional methods. So we don't have any conflicts of interest for the study itself, although, of course, I was brought out here by VisionRT. So for this presentation, I'll be going over data from two studies that we conducted as part of our evaluation. So the first is to look at whether or not the addition of surface imaging improved our setup accuracy for these SBRT treatments. And then the second, we looked at whether there was a difference between setting up patients to the DICOM reference versus the VisionRT reference captures that we take for each treatment, and to see, essentially if there's a difference between the two. I'm going to start with some background on the SBRT techniques and IGRT methods that we use at VCU, and describe our workflow for our patient setup. And again, the two studies that we conducted for setup accuracy, we were looking at couch positions for our treatments between imaging with and without surface imaging implemented, and then the second study on reference surfaces, as I mentioned. So at VCU, we treat SBRT with prescription doses ranging from 5 gray times 5 fractions up to 18 gray times 3, and our typical PTV margins range from about 5 to 7 millimeters. The sites we're treating are typically lung and liver. Occasionally we treat pancreas, pelvic nodes, and some spine metastases. So, of course, precision is very important, so we rely a lot on image guidance. With 2D KVOBI, we typically align to bony anatomy and fiducials. We use this to do rough corrections to the patient, such as we align the spine or rotate the shoulders and so on. We like to use KVOBI because it's fast to acquire relative to cone beam, at least. We push a button, we get our image. Although one caveat is that we do have to go in and out of the room to make our adjustments, and that's an important point to keep in mind when talking about surface imaging later. The other thing is, of course, KV imaging is ionizing, so we have to be mindful of how often we want to use KV images, and we're not really able to see the tumor or soft tissue. So for that, we rely on cone beam CT for our volumetric imaging. Compared to 2D, it's a lot slower to acquire. We have to wait for a half rotation or full rotation, depending on your site. And of course, it uses even more ionizing radiation, which is why we like to combine 2D and KV techniques. So 2D, we sort of get rid of some of the rougher misalignments at a much faster pace, and then we'll take our cone beam CT to do our tumor localization and our final positioning. So in order to treat our patient, the last cone beam CT must be approved by the attending physician. Now we add surface imaging into the mix. I think we're all experienced users here, so I will spare you from going into the details of what surface imaging is and how it works. But essentially the way that we use it is we implement it for initial patient setup, and what the advantage of surface imaging compared to the previous two techniques that I mentioned is that we can do all of our adjustments in the room in real time, so it's a lot more efficient, and of course without ionizing radiation, so it's also safer for the patient. And at VCU we have the AlignRT system equipped on a TrueBeam, and that's the machine that we treat all of our SBRTs on because we have the FFF mode. So all of our data comes from this particular setup that you see in that image. So the question that we want to answer is whether or not the inclusion of surface-guided imaging therapy gets us closer to the final treatment position determined by that last cone beam CT compared to traditional setup, laser localization. So this is a hot topic. It's going to come up again in some of the later sessions. We're really focusing more on how we do it at VCU for SBRT in particular, so that's what our data is focused on. What other people do might be very different from how we implement it. So this is just one way that we've chosen to incorporate surface imaging into our clinic. The study is a retrospective analysis, so we went back and looked at 295 SBRT fractions over 68 patients that were treated between 2015 and 2016. So 182 of those fractions were delivered before we had AlignRT installed, and then 113 of those remaining fractions were delivered after we started using it in the clinic. And again, just for a refresher, we have two different data sets that we're looking at. So I'm going to go through one study, go through, and then follow up with the second study. So our workflow for SBRT, our traditional method at least, is that we start with the laser localization, the 3 points to the skin marks, and then we apply any shifts to the treatment isocenter position if it's not the same point as the marked isocenter. We use our 2D KV-OBI to do our bony alignment, we fix our rotations, and then we perform rough shifts, and then we do our final target localization with cone beam CT. And one thing is, if we see any translational shifts greater than 0.8 cm in our cone beam CT registration, we will go back and take another cone beam CT to verify. So that's our traditional method, which you can see on the left side. That's our pre-AlignRT workflow. And after AlignRT, we've added it to the in-room setup phase after our laser localization and before our 2D KV-OBI. So to do our study, when you take a KV image, the couch position is recorded. It's attached to that image and saved in the record and verify system, which for us was ARIA. So we went back into ARIA. We looked at the couch positions on the first 2D KV image. So in the pre-AlignRT data, that tells us what the final position after laser localization is, where the couch was. And then in the post-AlignRT group, that's our final couch position with surface imaging. So we take that number, and then we look at the final couch position on the last cone beam CT, and then we compute the absolute difference between those numbers. And this allows us to directly evaluate what the setup accuracy is between lasers to cone beam and surface imaging to cone beam. And we did see a difference. So without AlignRT, our mean differences in our translations was between 0.5 and 0.6 cm, with the magnitude being greater than 1 cm difference. And when we add AlignRT, the differences reduce to between 0.3 and 0.4 cm, and the magnitude reduces to under 1 cm. So there's a big improvement. And you can see that in the vertical and the magnitude, these differences were statistically significant. And that's coming from the rank sum test with an alpha less than 0.05. We use the rank sum because the data is not normally distributed, so a t-test would not be valid. This graph displays all of those translations with the dashed line separating the time point before AlignRT on the left and after AlignRT on the right. And what you can kind of see here is that the distribution of our results is much tighter when we include AlignRT, and also we get much less outliers. So in the pre-AlignRT phase, we see gigantic shifts in occasional cases, and I'm going to go into a bit more detail with that. But you can see these box plots essentially show the same thing. In the vert and the longe, at least, the distribution of our translational differences is much tighter when we have AlignRT implemented into our workflow. So with those translational differences, without AlignRT, we saw maximum translations up to 12 cm, which is a very big shift. Obviously, in this case, the patient was probably set up to the wrong mark, or they were shifted in the wrong direction, which we wouldn't have caught until we took our KV image. So we can see when we have AlignRT, these large differences pretty much disappear. They're all within about 3 centimeters. So it saves us some imaging dose. It's a bit safer. And of course, it's also much more accurate to include surface-guided imaging therapy into our SBRT setup. In total, there were actually 6 shifts greater than 3 cm when we did not use AlignRT. So we're very happy with how we've implemented it in our clinic for setup accuracy. It's really helped us, and we think it's more efficient as far as our workflow goes. We feel like we take a lot less KV images, we take a lot less cone beam CTs, so we're not cone beam CTing as much when we have surface imaging. So that's the first question. Now the second question is, we've talked a lot about setting up to DICOM versus setting up to the reference capture that we take on the treatment machine. So what we want to find out is whether or not there's a difference between those two. Since we're in Atlanta, Georgia here, it's kind of like we have a peach and we have a nectarine. Is there really a difference? So the DICOM reference, that's our external contour. We use that for our first fraction setup. And then the VRT reference captures, we take that at every fraction after our final cone beam CT localization. And the primary reason we take those captures is to do intrafraction monitoring. But because we have them, we wanted to see if there was a difference between that and the DICOMs. Of course, here's an example of those two. On the left, we have the DICOM reference by itself, and then on the right, we have the Vision RT reference and the DICOM reference superimposed upon on top of it. And one thing about this image is, so this is a retrospective analysis. We went back and looked at all of the fractions that we treated, and we actually redrew all of the ROIs to make them as consistently as possible. We found that when we were initially treating the patients, we weren't paying that much attention to make sure that the ROIs that we were using for the registration were consistent, and we went back and made sure to remove things like the belly, which we saw earlier, can introduce a lot of uncertainties because of the breathing motion. So our goal is to reproduce the DICOM setup as close as possible. If everything is done right, theoretically, there should be absolutely no difference between these two, setting up to one versus the other. And the way we did our study is that we took all of these daily VRT reference images and we compared them back to the DICOM reference. And then we went again and actually took each of these daily references and compared them to the reference from the previously treated fraction, just to see if there would be any sort of difference from reference to reference image as well. And we found that there were no differences, so there's nothing statistically significant between the two. So basically, that's very good. That means that the system works, and that the references do a good job replicating the DICOM. Although I will say this is probably not the best way of doing the study, because initially the patients were all set up to DICOM. So it's not, what we really want is something closer to apples to oranges, and not the peach to nectarine. And the better way to do the study would be to prospectively separate our patients into two groups, half of them being set up to DICOM, half of them being set up to reference, and then seeing what the difference between that is. And that would be a very interesting data set to look at and see if, and probably reveal a lot more than the study that we did. But with what we found, we were comfortable with what we were doing. And in the end, we always choose to set up to the DICOM surface anyway. There's a reason, our reasoning is that when you set up to the reference, there is a chance that you might propagate any systematic errors. For example, if our tolerance for a rotation is 1 degree roll, and in our very first fraction, we have a 0.6 degree residual roll in our VRT reference. That's well within our tolerance, so we would capture that, it would be okay. Now, if we came in our second fraction and that patient was actually rolled 1.2 degrees in the same direction away from the DICOM, if we compared it to the first fraction reference image, it would only show up as 0.6 degrees. So that would be within tolerance, when in reality, it should, it would be unacceptable. It would be something that we should correct comparing to our DICOM, which is our sort of standard. So our final conclusion is that patient setup using surface imaging does give us get us closer to the final cone beam CT position compared to using just lasers. Again, we think it's a lot more efficient to have line RT because we can do our setup and corrections in real time in the room. We go in and out of the room much less compared to when we were relying on just 2D images. We've essentially, we use a lot less ionizing radiation, so it's safe for the patient as well. And as we'll hear in one of the later talks in the afternoon sessions, and it's a hot topic here, whether or not we can replace laser setup with a line RT or surface imaging completely. In our clinic, we still haven't yet. Part of it is that hump that we mentioned earlier, having everybody buy in. The therapists at our clinic, they're used to what they're doing. So even though it's more work, they still prefer to set up to the marks and then turn on a line RT and then use a line RT anyway. And then again, we didn't find any statistically significant differences in our reference surface study between the DICOM and the VRT. So, short presentation. That's all I have. If there are any questions, I will take them. Thank you very much.